Yeah. Good afternoon, everybody. Today, I will present a patient case focusing on cardiovascular rehabilitation for an individual with heart failure. The goal of this presentation is to evaluate an innovative training approach and determine how it can improve functional capacity and quality of life. The patient in this case is a hypothetical individual with heart failure with reduced ejection fraction. Based on his clinical data and functional limitations, I will recommend a training strategy guided by the ventilatory or lactate threshold. This method allows clinicians to prescribe exercise intensity based on physiological responses rather than arbitrary heart rate ranges. The prescription will first include the patient and summarize his clinical findings. Then I will explain why threshold guided training was selected as the most appropriate intervention. And then finally, I will discuss the physiological mechanisms behind this method and provide evidence-based guidelines for implementing it safely in a clinical rehabilitation setting. So, the patient in this case is Thomas Reynolds, a 64-year-old male. He is approximately 5 feet 10 inches tall and weighs around 198 pounds. He recently retired from his job as a maintenance supervisor because worsening fatigue and breathing difficulty made physical work more challenging for him. Mr. Reynolds has been diagnosed with heart failure with reduced ejection fraction, commonly abbreviated as HFrEF. This condition occurs when the left ventricle cannot pump blood effectively, resulting in reduced cardiac output and symptoms such as fatigue and shortness of breath. His medical history includes coronary artery disease, a prior myocardial infarction treated with a coronary stent, hypertension, type 2 diabetes, and hyperlipidemia. These comorbidities are common contributors to the development of heart failure. And overall, Mr. Reynolds represents a typical cardiac rehabilitation patient who does require a structured exercise program to improve cardiovascular function and to maintain independence. So, at his most recent clinic visit, Mr. Reynolds had resting vital signs that were relatively stable. His resting heart rate was about 82 beats per minute. His blood pressure was 132 over 78 millimeters of mercury, and his oxygen saturation was approximately 95% on room air. Diagnostic testing revealed an ejection fraction of 35%, which does confirm heart failure with reduced ejection fraction. His BP level was approximately 420 picograms per milliliter, indicating increased cardiac stress and fluid retention. His HbA1c was 7.4%, which is suggesting moderate control of his diabetes. Clinically, he experiences symptoms including shortness of breath with moderate activity, aropnia that requires him to sleep with two pillows, and mild ankle edema. These findings indicate that his heart failure is stable, but still functionally limiting. So, from a functional standpoint, Mr. Reynolds reports several limitations. He becomes short of breath after walking about 2 blocks on a flat surface. Activities such as climbing stairs, carrying groceries, or doing yard work causes noticeable fatigue and dyspnea. Physical examination also revealed mild crackles in the lungs, which can indicate pulmonary congestion from heart failure, along with bilateral atrial edema. Additionally, he also has mild peripheral neuropathy in his feet related to the diabetes. Despite these limitations, Mr. Reynolds remains independent in his activities of daily living. His primary goals are to improve endurance, reduce breathlessness during activity, and maintain independence. These goals align well with typical cardiopulmonary rehabilitation outcomes, such as improvements in VO2 peak and 6-minute walk distance, both of which are important indicators of functional capacity. So, based on the patient's clinical presentation, the selected intervention is ventilatory or lactate threshold guided aerobic training. This method involves prescribing exercise intensity near the point where ventilation and lactate production begin to increase more rapidly during exercise. Training at this intensity also allows patients to work at a level that is challenging but still sustainable. For patients with heart failure, this intensity often corresponds to moderate exercise, which provides a sufficient physiological stimulus when minimizing cardiovascular stress. Threshold-based training is commonly identified during cardiopulmonary exercise testing and provides a personalized way to prescribe exercise intensity. This method was selected because it is well suited for patients with heart failure who experience exercise intolerance, like Thomas here. Unlike high intensity interval training, which can be more demanding, threshold guided training allows gradual improvements and endurance in cardiovascular efficiency. Hypoxic or altitude-based training was not chosen here because reduced oxygen availability could increase cardiovascular strain and worsen symptoms in heart failure patients. Respiratory muscle training can be beneficial, but is typically used as an adjunct rather than a primary intervention. Threshold guided aerobic exercise offers a balanced approach that can safely improve endurance and functional capacity while reducing the risk of excessive cardiovascular stress. So, research strongly supports exercise training as a key component of heart failure management. Exercise-based cardiac rehabilitation has been shown to improve aerobic capacity, ventilatory efficiency, and quality of life in patients with heart failure with reduced ejection fraction. Improvements in VO2 peak and ventilatory threshold are particularly important because they reflect improved cardiovascular efficiency and they are associated with better functional outcomes. Studies also show that using physiological markers such as ventilatory thresholds provides more accurate exercise prescription rather than relying solely based on the heart rate ranges that we see. These findings also support the use of threshold-based exercise prescription for individuals with heart failure undergoing cardiac rehabilitation. And there are some advantages and limitations. First, it provides a personalized method of exercise prescription based on the patient's physiological response to exercise. Second, it allows patients to exercise at an intensity that improves aerobic fitness without placing excessive stress on the cardiovascular system. Third, it has strong support within cardiac rehabilitation programs. However, there are also limitations. Determining the ventilatory threshold usually requires cardiopulmonary exercise testing, which may not always be available in every clinical setting applicable. Additionally, improvements may occur more gradually compared to high-intensity interval training. Despite these limitations, however, threshold-guided training remains one of the safest and most practical approaches for many heart failure patients here. Exercise training improves cardiovascular function through several physiological mechanisms. One major adaptation is an increase in stroke volume, or SV, which improves the heart's ability to pump blood during activity. Exercise training also enhances peripheral oxygen extraction, basically meaning that skeletal muscles become more efficient at using oxygen rather than what they were before. Additionally, mitochondrial density and oxidative enzyme activity increase, which is improving the muscle's ability to generate energy aerobically. These adaptations collectively increase the VO2 peak and ventilatory efficiency, allowing patients to perform physical activity with less fatigue and shortness of breath. So the proposed exercise program for Mr. Reynolds would follow evidence-based cardiac rehabilitation guidelines. Training would occur 3 to 5 times per week. Each session would last 20 to 40 minutes, depending on the tolerance. The lower your tolerance is, the closer you'll be to the 20 minutes. And then the more that you gradually get used to the workout that's going to be happening, the closer to the 40-minute range that we'll see. It can be in between. That's just a usual guideline that we will follow there. Exercise intensity would be prescribed approximately 10 to 15 beats per minute below the ventilatory threshold, which corresponds to moderate intensity rather than the vigorous activity or the vigorous intensity that HIIT workouts usually apply. The recommended exercise nodes would include treadmill walking or stationary cycling, which over time, duration and intensity could be gradually increased as the patient's fitness improves. Safety and monitoring is key here. During exercise sessions, clinicians should monitor heart rate, blood pressure, oxygen saturation, and symptoms such as chest discomfort or excessive shortness of breath. Exercise should be stopped immediately if the patient experiences chest pain, dizziness, severe dyspnea, or abnormal blood pressure responses. Perceived exertion scales can also help ensure that the patient remains within a safe intensity range and does not fall out of the range that we are searching for. These monitoring strategies help minimize risk and also ensure safe progression of the rehabilitation program. And finally, we have reached expected outcomes. So, with consistent participation in a structured exercise program, there are several improvements that can be expected from this. These are including increased VO2 peak, improved ventilatory efficiency, and increased 6-minute walk distance. Patients often report reduced fatigue and breathlessness during daily activities. For Mr. Reynolds, these improvements could allow him to walk longer distances, perform household tasks more comfortably, and maintain his independence that he is searching for. Ultimately, the goal of cardiac rehabilitation is not to only improve physiological function, but to also enhance overall quality of life, which is the goal for Mr. Reynolds here. So, with everything considered, Mr. Reynolds is a patient with heart failure with reduced ejection fraction who also experiences monoral functional limitations. Based on his clinical presentation, ventilatory threshold guided aerobic training is an appropriate and evidence-based intervention. These training methods allow safe exercise prescription, promotes cardiovascular adaptations, and improves functional capacity. By implementing a structured and monitored exercise program, patients like Mr. Reynolds can experience meaningful improvements in endurance, independence, and quality of life. Thank you so much.